Welcome everyone. My name is Yasser Hamid. I'm a consultant psychiatrist in general adult and old age psychiatry, currently working with the older people community team in South Norfolk. We are based in Gateway House in Wyndham. Today, we are going to talk about old age psychiatry and about some of the cases that I came across during my practice, which I thought will have some learning values to you. It's always difficult when you are asked to present teaching for really wide audience who are from different backgrounds. So we have junior doctors, we have senior doctors, we have non-doctors as well, we have nurses and pharmacists and others who can also join these meetings. So it's really difficult to pitch your teaching to this really varied audience and satisfy their learning needs. So what I thought would be helpful if I just say a little bit about the older people community teams. So, if you want to refer to us patients, what are the referral criteria? What are the things that you should include in the referral? So I thought that will be relevant to, most people attending this teaching if they would like to refer people to our services. And then I thought if I can talk about some of the cases that I came across during my practice, which really made me think and made me more curious to know what's going on with the patient, and also to liaise with other specialties like neurology and geriatricians. So I picked up those cases that require this kind of multidisciplinary input, and I hope that these cases will be useful for you. So yeah, this is really the introduction I wanted to say at the beginning of this talk. The topics covered, as I said, will be introduction to our community services, tips for non-specialists in assessment of memory and other cognitive problems, and I think this will be relevant to our junior doctors, especially foundation doctors, core trainees, and GP trainees as well, and case-based discussions from my practice. The learning objectives I'm hoping to cover today would be gaining more knowledge about referral criteria for old age psychiatric services, but with the main scope on the community services, and also to develop your skills in cognitive assessment for patients with memory problems, regardless of their age. And the case-based discussions hopefully will highlight some insight into the management of complex patients with complex physical and mental health problems. Before I start my talk, really, I just wanted to have a moment to remember someone really dear and near to us who we lost earlier this year. Professor Tom Arey was a dear teacher and colleague. He used to attend these teachings in Hillsdon Hospital for years, and we are, most of us who have met him were really touched by this humble man, this generous man. Unfortunately, we lost him in June this year. And I just wanted really just to say a few words about him. Number one, if you are doing home visits to patients, please remember Tom Arey, because he was the one who pioneered home visits for patients from an early start in his career. Tom Arey not only developed these kind of the system of home visits, but also the working closely with our physical health colleagues. So especially with geriatricians, he believed that we cannot treat mental illness, especially in older people, without this close collaboration with the medics working in other fields like neurology, old age medicine. So please remember Tom Arey. It was a great loss that we have to endure this year. This year was also difficult, not only because of the COVID-19, but also it has kind of highlighted the issue of racism I've been in this country for more than 10 years, and I don't believe that this country is racist, but definitely we face a lot of what they call systemic racism and discrimination, which means that our systems can discriminate against people who come from different backgrounds. And I really would like to guide you or recommend this article, which was published in The Lancet, because I think we all agree that it is not enough now to say, I'm not racist. We have to be anti-racist. But the problem is that, as we mentioned, we live or we work in systems that has definitely some form of systemic discrimination against some people. So what can we do as individuals working in these systems to address these issues? This article really summarizes what you need to know about how to be an anti-racist and how to address systemic racism in your organization. For example, not ignoring the patient's skin color, but addressing the skin color of the patient and trying to understand how their skin color can influence their experiences of, living and working in this country, and how that affects their mental health problems. I think it's essential as a psychiatrist or as a mental health professional that you need to address these issues with your patients who are from Black or other minority ethnic groups. I run a clinic for refugees and asylum seekers in Norwich for a few years in the City Reach services. And I think addressing racial issues and discrimination was part of nearly every consultation I did with them, because it clearly influenced their mental health problems and kind of perpetuated their difficulties in integrating in this country. So that's all what I wanted to say about this important topic. So coming back to the main topic of today's teaching, so referrals for older people community teams. If you would like your patient to have a memory assessment, then you can definitely refer the patient to our services, regardless of their age. But I would say if your patient is very young, let's say in their 30s or maybe early 40s, and if they don't have any previous history of a psychiatric condition, and if they don't have any kind of current mental health problems, I would say in those younger patients, maybe a neurologist assessment would be more appropriate for them. You can refer to us patients under your care if the memory problems are not explained by their existing mental disorder and or medication. And I think we are all familiar with the concept of pseudo-dementia. So if someone has dementia or maybe has severe mental illness, that will definitely have an impact on their attention and concentration. And typically, you will find that these patients will have fluctuations in their memory problems with good and bad days, for example. And their cognitive difficulties are mainly around their short-term memory. So there is no speech changes, there is no major personality changes. So as I said, think about memory assessment, but also think about the existing mental condition and how that is affecting the cognitive function of your patient. And also think about referring patients with mental health problems to our memory assessment if there is a clear evidence that the memory problems are progressive, as I said, not fluctuating, and definitely have an impact on the patient's daily life. What we would like to see in the referral that you have thought about what they call the reversible cause of dementia. So you have done some blood tests to exclude reversible causes. These tests generally include routine blood tests, renal function, liver function, vitamin B12, folate, and any other relevant blood test that you think may be indicated in this patient, just to exclude reversible causes of dementia. You may wish to do a brain scan even before you do the memory assessment, especially if the patient is presenting with, let's say, for example, other neurological signs, or there is decline in mobility, or recurrent falls, or history of head injury. So you may want to do a brain scan even before you refer the patient to us for memory assessment. And I think needless to say that the patient is willing and consenting to the memory assessment referral, because unfortunately sometimes I had referrals when, where the patient really didn't know that they were referred to us and didn't want to engage in the memory assessment at all. So just make sure that the patient is consenting to this referral. But if you believe that the patient lacks capacity and they cannot give the consent, also, put that in the referral letter. And also it will be very helpful if you give us contact details for a member of the family that we can contact, who can attend the appointment, and who can also provide collateral history. What are the tips for making a good referral? Give as much details as possible, and I cannot really kind of overemphasize the importance of this. The more information you give, the higher chance that we will make a decision that will satisfy you and also will meet the needs of your patients. Number 2, focus on changes in other cognitive domains. So don't only say that this patient is having short-term memory problems, they are forgetting appointments, they go to one room and they cannot remember, why they went there. These memory difficulties are very common and are non-specific. We need to know if there has been any change in, as I said, the other domains, other cognitive domains like speech, like orientation, personality, planning, organization, executive function. So try to highlight the change in these other areas when you are making the referral. Now, this is an example of a referral we received, I think a couple of months ago. I hope you are able to read it, but we don't have the time to read it all. But honestly, this is a screenshot from a GP referral to a memory service. I mean, I would be extremely happy, in receiving these referrals from you as well. So I'll just give you a few seconds just to have a look at it. So the GP is highlighting the medical history of the patient. The referral describes the current difficulties in really good details. Poor concentration when completing simple tasks. Lives alone in a bungalow. This is also very important that we need to know, what is the social situation of the patient, who is there to help them. And all of these things will also help us to prioritize this referral. I mean, will this patient be safe to wait for 4 weeks to be able to have the assessment, or do we need to prioritize this assessment? The referral also mentioned some cognitive assessment in the primary care, which was also very useful, and ECG. Okay, so this is a really good referral that I would like you to really aspire to do to our memory services. On the other hand, this is also another referral we received about a few months ago. And again, this is really screenshot of the referral. So declining memory, forgetting appointments, lives with wife. That's all what we got from this referral. It's really important to have a good referral to enable us, as I said, to prioritize this referral. And when we go and see the patient, we will have in mind what are the areas of concerns that we need to focus on. Okay, so you have a patient, and this patient is complaining to you of memory problems. So what do you need to do? And I think this is this saying from this Scottish physician in 1883 really summarizes what you need to focus on and taking history from a patient with cognitive decline. What sort of man was this when he was reckoned well in mind, and how does he now differ from his state then? And I think this also highlights the importance of having a collateral information from an informant who knows the patient, because some patients will not know, if these changes have happened, or, they will have limited understanding about the impact of these memory changes on their day-to-day life. But having an informant with you during the assessment will really highlight these changes. And again, when you are thinking about assessing memory in your patient, please don't focus only on the short-term memory, because as I said, these changes are non-specific, but focus on these other areas. The MA6. So M for memory, A for apraxia. It is the inability or the loss of function. So yeah, inability to, for example, putting their clothes on, or putting their clothes, back to front, very common problem in dementia. It denotes or it defines generally the inability to do the things that they used to do. So how to operate, let's say, a remote control, how to operate their washing machine, which they had for many years. Okay, so that's the apraxia. And then we have the aphasia, so speech difficulties. Agnosia, it is the inability to recognize things. And then abstraction and other executive functioning is really important. So planning, organization, keeping their appointments, taking their medication, very important task as well. It requires a bit of planning to remember to take your medication, plus absence of clouding of consciousness and ability to function is impaired. And again, this is so important. Please let us know what is the functional impairment from these memory problems or the cognitive changes, because many people will have some cognitive changes, but without any impairment in the functioning. And what do we call this? What do we call this kind of symptoms when there is a cognitive decline, but there is no impairment in functioning? Mild cognitive impairment is when there are cognitive changes. Definitely, when you do a cognitive test, they are, the patient is scoring below what is expected for a normal population, but there is no significant functional impairment in the day-to-day life of the patient. And people with mild cognitive impairment, if we followed them up for 3 years, 1/3 will get better, meaning that their difficulties maybe was due to a reversible cause or stress or bereavement. So 1/3 will get better, 1/3 will stay the same. So it's not a progressive condition, and 1/3 may develop dementia. Okay, so there is a higher risk compared to general population in developing dementia. The patient has mild cognitive impairment, and therefore, usually we will say to the GP, please re-refer in a year's time, especially if the problems are getting worse. Thank you. Okay, now I just wanted to mention this, the functional cognitive disorder, because we receive a lot of referrals, and especially for patients who may have some other neurological condition, or they have been investigated by neurology. But, there is no organic cause for their cognitive difficulties, and they are still within the range of mild cognitive impairment. Okay, so we call this functional cognitive disorder, meaning that there is cognitive impairment, but it's mainly functional. It's mainly due to poor attention and concentration. It is not dementia. It is not going to get worse. So as I said, there is absence of relevant neuropathology. So if you do a brain scan is completely normal, blood test completely normal, but the patient continues to to report these significant cognitive problems. Sometimes, even, changes in their speech, inability to engage in conversation, short-term memory problems, and perhaps even personality changes as a result of these difficulties. But they remain functional cognitive disorder. And in these cases, usually you will see them stable over a number of years. So when you read their GP record, there will be repeatedly maybe reporting these memory problems or having memory assessment in the past 5 or 10 years, and they still are in the same level of functioning. And if you do the memory testing, they will score nearly the same, 5 years down the line. So there is some stability in their presentation. And the treatment is really mainly reassurance and addressing maybe the psychological factors that are contributing to their functional illness. I'm not going to go into the details of that because of the time, but yeah, there are various types of functional cognitive disorder. There is one related to hypochondriacal disorder with dementia as a focus. We see this especially with people who may have a parent who was diagnosed with dementia, and they are so worried that they may develop dementia. And these are some of the clinical signs. As I said, I'm so sorry I have to rush through this, but you will have a copy of the slides. But basically, typically the patient will be attending alone. They will be able to provide detailed answers about previous memory failures and personal history, answering quickly. The patient is more worried than others, and we see this as well when we do the memory assessment, is that, when you ask the partner or the other members of the family, they don't think the patient has that level of cognitive change. And the patient may also remind you about the previous things you have said to them, or they have said to you. So they have definitely an intact ability to retain information and repeat that information, which is really not consistent with something like dementia, for example. So case one, very quickly. So we have 5 minutes. 55-year-old lady, known diagnosis of cerebellar ataxia, referred to memory service due to worsening cognition. And she didn't have any psychiatric history. So I initially assessed her in 2018 due to similar memory problems. We did the ACE, Addenbrook's cognitive examination, and she scored 77 out of 100. And for those who are not familiar with this test, with the ACE, any score above 88 is normal. Scores between 82 to 87 or 81 to 87 will be mild cognitive impairment. Scores below 72 will be highly suggestive of dementia. Okay, so she scored 77 out of 100 with significant impairment in fluency and memory. And my impression was at that time that she was most likely presenting with mild cognitive impairment because, she was living independently in the community. She didn't need any package of care. Her mother was helping her with some aspects, but there was no significant impairment. And I also noted that she had a brain scan in 2014 and 2018, and both were really showing non-progressive changes. So there was cerebellar atrophy, which is really seen in cases of cerebellar ataxia, but there was also generalized cerebral atrophy, but these changes were stable over a 4-year period. So if you are dealing with a condition like dementia, you would expect that these changes will be progressive. Okay, so at that time, we didn't feel that there was a progressive, a condition such as dementia. And we discharged her with a diagnosis of mild cognitive impairment in 2018. In 2020, just a couple of months ago, the GP referred her back to us. There has been significant decline over the last 2 years in all of her cognitive abilities. So short-term memory definitely got worse, speech got worse, and she now needed a package of care in place because her mobility also got worse over this last 2 years period. She had frequent falls, frequent head injuries, and still she is not presenting with any psychiatric symptoms. She was wheelchair bound at this time when I saw her in 2020 because of this significant decline in mobility, which we see in her existing condition, the cerebellar ataxia. Now the ACE has dropped by 15 points from 2018 to 62 out of 100, with significant impairment, again, in memory, fluency, but also in language and visuospatial abilities. So even her ability to repeat words or draw a cube or a clock significantly deteriorated compared to 2018. Okay, so at this point in time, what other test would you like to do? So lady, cerebellar ataxia, 55 years old, significant global cognitive decline. MRI in 2018, cerebral atrophy and cerebellar atrophy. What else would you like to do? I should also mention that she had genetic testing to exclude any genetic cause of early dementia, and all of these tests were negative, including C9orf72. But this genetic test is very important when you are suspecting early onset dementia. Okay, so the main question I was faced with is this decline consistent with cerebellar ataxia, which is characterized, as I said, by cerebellar dysfunction and cerebral atrophy, or is there a second condition on top of the existing cerebellar ataxia? So are we dealing now with early onset dementia on top of the cerebellar ataxia? So she is under Addenbrooke's Hospital, and they have requested the brain scan, but we don't have the results yet. She didn't do it. Can I just ask, can someone tell me the functions of the cerebellum? Because if we understand the functions of the cerebellum, we will be able to understand her presentation. So what does the cerebellum do? Is it only for more kind of coordination of movement, or is it something else? Does it have any role with the speech, the cerebellum? Because, as I said, this may explain the decline in her ACE scoring. What do people with cerebellar disorders present with in terms of their speech?
It's like a dysarthria or staccato speech.
Absolutely. So the decline in her existing condition caused her to not perform very well on the speech domains in the ACE, because in the ACE you are asking the patient to repeat words and repeat phrases like, all that glitters is not gold. And all of these functions will be impaired in patients with cerebellar disorder because of the dysarthria. Okay, so the articulation of the speech is all over the place. And she is losing points because of the cerebellar condition. What about the visuospatial decline we've seen? Is that also consistent with cerebellar disorder? Now, clock drawing test. Would someone with advanced cerebellar disorder be able to do a neat and nice clock drawing in the ACE?
They might have symptoms of nystagmus, so that might affect their ability to kind of draw.
Absolutely. So really, she lost all these points, 15 points on the ACE in a space of 2 years, not because she is now developing dementia, but her cerebellar condition is getting worse. So following discussions with the neurologist, they did say that this is unlikely to be a second diagnosis. She is presenting with the later manifestation of cerebellar ataxia. Okay? So we discharged her with this diagnosis that, we don't feel this is dementia. We don't feel there's any benefit of trying memory medication in this lady. However, these are the later manifestation of her existing condition. But as I said, it just highlights the importance of us thinking about the existing neurological condition and the manifestation of that condition on the patient's cognition. Okay. Case 2, so this is 67-year-old lady, bipolar affective disorder, on sertraline, lithium, promethazine, use as needed. She was on quetiapine couple of years ago, but this was stopped and changed to lithium. She presented with abnormal movement of the tongue and lips, constantly smacking, protruding her tongue, and has absolutely no control over these facial movements. And these symptoms were also associated with some speech difficulties as well. She had a dental plate, and she said initially that the movement will get worse when she put the dental plate. And to cause matters worse, she had malalignment of the dental plate. So I thought maybe these are related to the dental plate, and we asked the dentist to review this. But definitely the abnormal movements of the tongue and the lips continue to get worse and worse, even though she has removed the dental plate. And there are no other neurological symptoms and no other problems associated with her physical health. So what are these movements? But tardive dyskinesia, a very bizarre, really, presentation for someone who is not on antipsychotic medication. So the neurologists blamed promethazine for this condition, although she was using the promethazine really very, very, very sparingly. So I would say, one tablet, 25 milligram every 2 weeks. And she was on it for about 6 months or so. But the neurologists have confirmed that this tardive dyskinesia is most likely due to promethazine, which we definitely stopped. There are some case reports that say that promethazine is associated with tardive dyskinesia without even antipsychotic medication. And there is only one case report of a patient who developed tardive dyskinesia on lithium when they were on lithium only. Okay, so it was very bizarre case. And unfortunately, of course, when we stopped the promethazine, it didn't lead to any improvement. And we started her on tetrabenazine, which has some positive effect, but the movements are still there. She was also on propranolol for tremor due to lithium, and that seems also to be helpful for the tardive dyskinesia. So these are just really examples of tardive dyskinesia and tardive akathisia and the management. Okay, so moving swiftly on to case 3, we have 70-year-old man, previous history of depression, presented with severe episodes of lightheadedness, dizziness, and shortness of breath in response to noises in his head. Really very, very very curious case. So this gentleman is presenting with severe dizziness on waking up in the morning when he stands up from bed. And then the dizziness and lightheadedness will be then associated with shortness of breath and feeling that he's going to die as a result of noise disrupt, how can I say it, some auditory experiences in his head. So for example, when he uses an electric brush or even a normal toothbrush, the noises from brushing his teeth will go inside his brain and become more exaggerated and more rhythmic even after he stops this activity. And that will cause the dizziness to get worse, and he will have these really panic-like symptoms of shortness of breath, inability to breathe, calling the paramedics, and just generally very unwell. So he has been investigated by the ENT, by the neurology. He has right-sided sensory neuronal hearing loss, and the MRI showed some moderate small vessel disease, but otherwise normal. And his symptoms were thought to be psychological. So I went there. We did an ACE as well, just to exclude any other memory problems, because he did report some memory problems. His ACE score was 84, so mild cognitive difficulties. Just to make things more complicated, he has a sleep apnea, could not tolerate CPAP machine, but he had another sleep study and they didn't feel that he needs a CPAP machine. What I did is that I thought, okay, let's switch quetiapine to mirtazapine to reinforce the effect of the venlafaxine and maybe reduce the tiredness and sedation that he was experiencing. And instead of making any good to him, he developed this taste disturbance as a result of mirtazapine, dysgeusia. Don't know if I'm pronouncing right, but he reported that since starting mirtazapine, everything he eats feels like a rubber. When he chew or eat meat, for example, it feels like rubber. There's absolutely no taste. So we stopped the mirtazapine, and this has improved. Okay, so what is going on in this patient? So you have dizziness, and then you have symptoms of panic disorder or panic attacks, and everything else is normal. Blood pressure is normal, heart is normal, neurology say it's normal. So what's going on? So the diagnosis is hyperventilation syndrome. And if you read the criteria for diagnosis, they definitely really describe the condition of this patient. So excessive breathing when he's anxious. So when the dizziness comes, he becomes more anxious. And then he has the hyperventilation symptoms, and then dyspnea and anxiety and reduction of the PCO2. And guess what? He is breathing now into a paper bag, and these attacks are much less severe. So definitely this was hyperventilation syndrome. And the dizziness can be explained by this condition, persistent postural perceptual dizziness. Again, functional psychosomatic illness in which the patient feels extremely dizzy when changing movement. So this was a psychosomatic kind of condition, but it was too complex, and it really required the input from, as I said, sleep clinic, respiratory team, ENT, and also the neurology and the hearing therapy. Case number 4. So we have 4, 5, 6. So we have 3 cases. I'll move very quickly with those so that I allow time for more discussion at the end. So this man, again, one of the really strange cases I've been involved in over the last year. 62-year-old gentleman moved recently to a care home following repeated and prolonged admissions due to falls and head injuries, which resulted in significant cognitive decline and inability to cope at home. So this gentleman has a diagnosis of myotonic dystrophy. It's a familial disorder. It happened later. The manifestation happened later in his life. Until June last year, this man was driving his car without any problems, absolutely no cognitive difficulties. Speech was normal, was living at home with his wife. And then he had these repeated falls and significant head injuries, I think starting from August last year until January this year. Okay, each fall resulted in bleeding and a stay in the hospital. And there were definitely features of delirium during these hospital admissions. So he was presenting with more kind of agitation, aggression during these admissions. But yeah, just really significant decline from the man he was in the summer of 2019. And imagine, during a short time, he ended up in a care home. Brain CT scan showed resolving right frontal subdural hematoma and some vascular changes. So his brain, you can call it a vulnerable brain. So he already had some risk factors for dementia. He had vascular changes, and then he had these traumatic brain injuries. But as I said, no evidence of significant cognitive decline before his admission following a head injury in the summer of last year. In November last year, just before they discharged him to the care home, they did an ACE3 and he scored 30 out of 100. He was extremely impaired, although there was no evidence of delirium at that stage. So the delirium has resolved. He remained very cognitively impaired. Now, he went to the care home in November last year, and there was some improvement in his cognition. So, so he was able to recognize his family, his speech was better, And then unfortunately, he had another fall in January with head injury, admission to hospital, and his cognitive decline kind of worsened again. So the GP referred him to me in March this year with behavioral challenges in the care home. He was extremely confused. He now became double incontinent, and he was refusing to wear his incontinent pads, constantly shouting. And I say constantly, day and night, shouting the name of his wife. And even when the wife was visiting him, he will continue shouting her name because he wasn't able to recognize her. At that time, he was on citalopram. So what do you think is going on? Is this dramatic decline consistent with repeated head injuries in someone with, as we said, with a vulnerable brain? Or is this dementia? So he had definitely vascular changes, bilateral basal ganglion, lacunar infarcts with a chronic small vessel disease. And so definitely, yeah, I agree. So there was a higher risk, definitely, of vascular dementia in this case. And then the traumatic brain injury happened. But as I said, would you give the diagnosis of dementia to that patient, or would you like to wait a little bit more because of these fluctuations in his cognitive functioning? And by the way, the last fall he had, as we said, in January, since January, he didn't have any falls. His cognition, unfortunately, didn't improve. The shouting reduced. The orientation slightly improved. He's able to recognize his family, but he remains really needing significant amount of care, to eat and drink and, for his personal care. So there hasn't been any improvement in his cognition, but there hasn't been any decline since January.
I think I'd go with the trauma theory and wait a bit longer in case there's inflammation or anything that can kind of marginally resolve before diagnosing him with what is a pretty devastating diagnosis if you receive it of dementia. I think I'd go with trauma first and foremost and then watch and wait, I think is my answer.
And Joe, two consultant neurologists completely agreed with your opinion. So they said, yes, this is not likely to be dementia, and this is related to traumatic brain injuries as I said, on a vulnerable brain. His brain was already vulnerable, although the family didn't notice any cognitive decline before the major fall he had in the summer. The neurologists were convinced that this man did have some cognitive difficulties before the fall, and then you have the falls. But then, as you advised, we didn't give the diagnosis of dementia. We gave a diagnosis of cognitive decline following repeated traumatic brain injuries. And we know that people with traumatic brain injuries have definitely higher risk to develop dementia. However, you only need to watch and wait so that you see where the patient will plateau. Will they get better? Will they stay the same, or will get worse, which is suggestive of dementia? However, what I've done with him is that when I saw him in March, and due to the significant cognitive decline and the behavioral challenges, I didn't want to try an antipsychotic medication, but I thought I'll try memantine. Now, this is a completely off-license use of this medication in someone with cognitive impairment and traumatic brain injury. But I thought to myself, there are definitely brain lesions. There's definitely this history of the neurological condition. I'll go for memantine. There has been some few case reports of using memantine in traumatic brain injuries or other neurodegenerative conditions without dementia, and they showed some success. And the introduction of memantine definitely helped the presentation of the patient. So that's really, as I said, the lesson from this case is sometimes you just need to watch and wait. You don't have to give the diagnosis straight away, especially in these complex cases. Now, case 5, 65-year-old gentleman, previous diagnosis of normal pressure hydrocephalus, which was treated with a shunt last year. So he had normal pressure hydrocephalus. He definitely had the cognitive impairment, incontinence, and mobility decline last year. He was seen by the neurologist and the neurosurgeons, had a shunt operation, last year at Addenbrooke's Hospital, but then his cognitive decline continued. That was very bizarre. The shunt was successful, the mobility slightly improved, but this man continues to, and the incontinence as well improved, but this man continued to have significant cognitive decline in short-term memory and speech. And not only that, when I took the history, they did say that there was some improvement, as I said, even in the cognition, but definitely declined again after the operation. And then when you took the history, detailed history, you will find that the patient was actually presenting with visual hallucinations dating back to probably 2 years. So even before the diagnosis of normal pressure hydrocephalus, this man was seeing people in his house and seeing spiders on his hands. So when you talk to him, he's kind of constantly trying to, push away these spiders. But the onset of these symptoms was 2 years ago, but they weren't really very recurrent and very disturbing. And this is why he didn't really report them to the neurologists when they saw him for the cognitive decline and the mobility decline. And he was also presenting with vivid dreams, really nightmares that will stay in his mind even when he wakes up, and also wandering at night. And all of these symptoms, as we said, were present before the diagnosis of normal pressure hydrocephalus, and they got worse recently. So what happened? Did we miss something with this man? Did we miss a second diagnosis? So you have visual hallucinations, cognitive decline, mobility decline. That's correct, yes. So this man actually presented with 2 diagnoses at the beginning, 2 to 3 years ago. He definitely fulfilled the criteria for Lewy body dementia and normal pressure hydrocephalus, but because of maybe he didn't report these things, or maybe they didn't ask him about these things, they focused on the normal pressure hydrocephalus. The shunt was successful. The shunt did slightly improve the mobility, but we are left with the other features of Lewy body dementia. So we did a DAT scan for him. That's the dopamine transporter scan, which definitely shows significantly reduced uptake in the basal ganglia. So again, this case just highlights the diagnostic complexity of these patients, and sometimes you need to think that the patient may be presenting with more than one condition. And the final case, a 79-year-old gentleman presented with subacute onset of cognitive decline, visual hallucinations, and persecutory delusions. And I'm saying subacute because the wife of the patient reported that the decline really happened after the lockdown. So she noticed that at the end of March this year, and he was referred to us in June, so 3 months later. So this is why I mentioned subacute. He was seeing a face of a woman in the vase and starting calling her Mrs. Flowers. And there were also periods of verbal aggression towards his wife, as he became very suspicious that she has a double, and he would question her to know if she was his real wife or not. Not only that, he would question his friends. He will ask them, let's call his wife Judy, do you know Judy? And they say, yeah, of course, she is your wife. Oh, do you know she is real? Do you think there is a double? So he was also checking with his friends about the identity of his wife. He really believed she was a double and she was not his real wife. And even if she answered all of his questions about the holidays they went to, where did they meet, he will still be very suspicious of her. And also they noted some mobility decline, significant personality changes. So he was a very social person, but he became more withdrawn. His conversations were really affected, and he was just really giving short answers. And all the tests are normal, including brain CT scan. So what is the diagnosis? So again, cognitive decline, mobility decline, and visual hallucinations.
Frontotemporal dementia.
Frontotemporal dementia could be a possibility. Even if you have a normal brain scan, yeah, it could be, but it's just the age, really. He's 79, so not really very typical. And not really associated with the mobility decline we've seen and the visual hallucinations.
Paraphrenia?
Paraphrenia, so late onset schizophrenia could be. But what about the significant cognitive decline? He definitely, when we did the ACE scoring, I think he scored 65 over 100, although he was a highly intelligent man. This man used to be an engineer, and he was doing training courses as well.
Is dementia with psychosis a thing?
Normal pressure hydrocephalus could be, absolutely, but in his case, the brain scan was normal. There was no signs of really normal pressure hydrocephalus, so no dilatation of the ventricles. But that's a good condition. But just dementia with psychosis, that is correct. But what kind of dementia would you give him? Mobility, hallucinations, and cognitive decline. Which dementia would that be?
Lewy body.
That again, Lewy body, isn't it?
And the thoughts about the wife, it's Capgras syndrome. I remember being, sitting the MRC psych exam, and Capgras and Frigoli were really very popular syndromes in questions, but we really don't think about them too much when we do our clinical practice. And he definitely had Lewy body dementia, also confirmed by a neurologist later on. And he had this Capgras syndrome, which is believing that someone they know is a double, has been replaced by an imposter. And the theory behind Capgras syndrome is really fascinating. So you have two brain damage that prevent familiar faces from evoking an emotional response. And the second impairment is preventing the ability to reject the delusional belief. Okay, so this is why the person is presenting with these delusions, is that the face of his wife is really not evoking any emotion, and also his ability to reason and rationalize has been lost. So there is a disconnect in the pathway between the temporal lobe and the limbic circuits. So that's all.